Topic of discussion is liver function tests. So, how many of you like the liver? I like the liver. Okay, what is liver? It's a major organ. Liver is a major organ. Liver is also a gland. Okay, and it is the largest organ. It is the largest organ of the human body. Okay, so this plays an intimate role in different kinds of metabolism and their intercombination. Liver is the organ which has the largest resistive capacity against any pathology. Any pathology will reflect on the panel of liver. It is the prima facie place of metabolism, interaction and infection control. Okay, and majorly this is the only organ which has the capacity to detox your body. Okay, so liver is one of the most important organ. So what is LFT? LFT is just a panel of blood parameters. It's a panel of blood parameters or analytes that can give you a clear picture of what is the situation in the liver of a person. Because any disease process will reflect in your liver function test, it will reflect in your renal function tests. So these tests are prescribed as routines. These tests are prescribed as routines to complement the amount of physiological stress that the body is undergoing and how much capacity does the body's buffering mechanism have before serious organ damage can take place. Okay? So, what should you know after this class? Most likely nothing. Okay? You understand the major metabolic functions and the major liver dysfunctions, the major causes of liver dysfunction. You discuss the markers that will allow you to detect hepatocytic injury and assess hepatic function, which is a major buffer for against all disease processes. Okay. So what are the major metabolic functions of liver? Does it produce anything? Okay, very good. So first thing is synthesis. It has got a synthesizing function, right? It has got a synthesizing function. So synthetic function. What does it produce? Plasma proteins. Okay. Coagulation factors. Albumin, globulin. It is the seat of lipid metabolism, formation of triglycerides, breakdown of triglycerides occur intrinsically in the liver. Then we have got detoxification and excretion. A major amount of ammonia that is produced via ammonia is produced from where? Which reaction? Transamination, deamination? Yeah, deamination. What is the name of that enzyme? Transaminase plus deamination. Glutamate dehydrogenase. Okay. So it is the seat of transamination and the only way to remove the ammonia group to get your ketoacyl counterpart. Okay? So, major detoxification function, formation of urea, formation of bilirubin, Vitamin K is essential for what? For clotting factors. So whenever the body is in stress or strain, especially when you will advance in your further classes in gynecology, you will be taught eclampsia, pre-eclampsia. You will learn about HELLP syndrome, which are life-threatening conditions for a mother. And the only way for you to assess and save the patient is through assessing your liver function. Okay? When you will reach final year, maybe you will recall this thing which I told you just now. Okay? It is also the major storage for all fat soluble what? Fat soluble what? Vitamins. Very good. And finally, production of bile salts. What does bile salts do? I have told it so many times during practical classes. It causes digestion of lipid, it reduces the surface tension, it breaks down the fasciae so that the triglycerides and the free fatty acids can be absorbed from your intestine. Okay? So these are your major metabolic functions of the liver. So what things can happen that will cause injury to the liver? If you remember your anatomy classes, liver consists of cluster of mesenchymal structure, hepatocytes. Hepatocytes. These hepatocytes are connected by small pipes. Those pipes are called hepatic canaliculi. Okay. The entire network of canaliculi will come together to form common hepatic duct. That common hepatic duct will combine with which duct? Right. Pancreas to form what? Hepatopancreatic duct. And finally, the common bile duct will merge with the pancreatic duct to what? Hepatopancreatic duct, which will open in the ampulla of Vater, where in the second part of the liver. So that is the anatomical structure. You see the beauty. At each and every anatomical niche, there is a specific cell. For each and every specific cell, there are enzymes which are internalized in those cells. So if those cells are damaged, then those entities will be released and that will be reflected in your blood by LFT. So even much before a patient develops jaundice, before a patient develops fever, before a patient develops edema, you will be able to diagnose and stop the disease process just by looking at LFT. That is the beauty of this. That is the beauty of this parameter. Okay? So what things can go wrong? There can be hepatocellular diseases. That means diseases of the parenchymal cells itself. Hepatic parenchymal loss. Hepatocytes are getting injured. Then there is cholestasis. What do you mean by the word cholestasis? Where? In common bile duct, if there is stasis, we will call it cholestasis. No. It is only for the canaliculi. Those fine drains get obstructed. In further down the lane in your medicine, you will be taught about Carelli's disease. Okay? Where this entire network of ducts are not present only. And the only way to save the life of the patient is a liver function. There is a liver transplant. Okay, that you will learn when you will learn the hepatocytic system during your medicine classes. Okay, so cholestasis, obstruction and bile flow at what level? At the biliary canalicular level. Okay, then there is cirrhosis. What do you mean by cirrhosis? Cirrhosis is an anatomical diagnosis. At first, when the liver gets injured, it will balloon out. This condition is called hepatomegaly. Okay. When this recurrent damage goes on, after a time, the liver cells will be replaced by fibrous tissue. And I have told you numerous times, what is the nature of fibrous tissue? They will shrink. they will shrink, and slowly your liver will become smaller and smaller. Okay, that condition. But cirrhosis is basically a histopathological diagnosis. There are 4 parameters to detect cirrhosis. That belongs to pathology, and the pathology people will tell you. I will not tell you in this class. Those who are interested, you please look it up. There are 4 points that you have to match in the slide of our liver so that you can declare that the person has liver cirrhosis. So do not utilize this term casually. It means a permanent damage. It means permanent damage for which the patient likely will need to go for a liver transplant. Okay? So I would suggest you use this word cirrhosis very carefully. Hepatitis, very easy. Inflammation of liver parenchyma. Okay, inflammation of liver parenchyma. Then we have got jaundice. Jaundice is increased bilirubin levels greater than 2 milligram per dl. Okay. Now there are so many variations to this. I will try to cover it. It's so impressive. Okay. Then there are liver cancers. Okay. Steatosis, fatty liver disease. Fatty liver mainly in Indian population it belongs to 2 distinct classes. The first class is NASH. That is non-alcoholic steatohepatosis. That means the patient is not an alcoholic. It is a genetic predisposition which causes deposit of fat or lipid granules in the hepatocyte themselves, thereby impairing them to perform their function. And another is alcoholic liver disease, in which due to excess ingestion of alcohol, due to excess proliferation of aldehyde dehydrogenase and alcohol dehydrogenase, slowly but surely hepatocytes get injured due to the overwork and the overcompensation that they have to do, along with maintaining the normal body functions. Okay? So that is steatosis. Finally, genetic diseases, huge list of them. Huge list of them. Okay? Each and every anemia, hemolytic anemia, non-hemolytic anemia will cause liver dysfunction. Okay? Or thalassemia patients. If you see a thalassemia patient, you will see huge liver. Hepatomegaly, severe hepatomegaly, a huge spleen. Because the reticuloendothelial system is present in the liver and spleen. Okay? And they are the chief place where the destroyed RBCs will be collected and they will be filtered away from the system. So that is why you get a huge hepatomegaly, you get a huge splenomegaly. Okay? In case of autoimmune hemolytic anemias like thalassemia. Okay? Moving on. Non-invasive methods of liver dysfunction. If you consider a venous plaque as non-invasive, definitely it is non-invasive. Okay. Identifies, gives a general idea about the type of disorder and definitely helps to assess severity and allow production of outcome. This is the major role. It assesses the severity and allows the prediction of outcome of the disease. Okay, this is the major role. Then there is disease treatment and follow-up. So in order to detect hepatic injury, it may be mild to severe, it can be acute, it can be chronic. Okay? The nature can be either hepatocellular injury or it may be cholestasis. And in order to assess hepatic function, especially sympathetic function. Okay? So what are the markers of liver dysfunction? First is serum bilirubin. Okay? Total and bilirubin. Then there is routine urine. That is bile salts and urobilinogen. This is being detected in urine, not in blood. Okay? Urobilinogen and bile salts are being detected in urine, not in blood. That is your total protein, serum albumin and albumin liver protein, albumin levels and globulin levels, which is the marker of liver function, so important. যদি ঘাটে তাহলে কি হবে? ঘাটলে কি হবে? কমে গেছে। Yeah, regular physiology, right? If the level of albumin and globulin decreases in your blood cell, what decreases? Plasma oncotic pressure decreases. So if your plasma oncotic pressure decreases, then your capacity of blood to suck in fluids from interstitial space will increase or decrease. It will increase or decrease? It will obviously decrease. Basic diffusion. See, I will show you. This is your capillary. Okay? This is your cell. Diffusion, fluid moves from high concentration to lower concentration or lower concentration to high concentration. High concentration to lower concentration. So the main concentration of your plasma is your plasma proteins and red blood cells, WBCs. Those are mostly they do not increase or decrease. They are in a specific amount particular unless something is grossly wrong. Okay. So now, if your albumin and globulin decreases, then what will be the osmolarity here? It will increase or decrease? It will decrease. If here the plasma oncotic pressure decreases, if here the osmolarity decreases, will you be able to absorb water from this interstitial space? Yes or no? No. Then now you have fluids in your interstitial space, in your interstitial cells. Now imagine the same thing. In brain, there is water in your brain medulla cells. That condition is called cerebral edema. You have got the same thing in your lung. That is called pulmonary edema. Okay. If you have it, if the entire body is compromised, then the maximum amount of water and excess blood space will go down to your feet and you will have pedal edema, heart failure, protein leverage malnutrition. This is the most important role of your serum albumin and globulin. Okay? This is the pathogenesis of edema. Should be counted. I told you right away. Okay? So that is the major role that is being played by your serum albumin and globulin. Now I will tell you the scenarios that I face in my day-to-day clinical care practice. Okay? The patient is in septic shock. All the arteries are dilated. The capillaries are fragile. Whatever fluid is coming out in the tissues, blood pressure is increasing. Blood pressure is increasing, but you need to get rid of that excess fluid in your tissues. The patient is in pulmonary edema, not being able to breathe. The only way you have is Lasix or diuretics. You are pushing diuretics. Diuretics is supposed to lower your total blood volume. Total blood volume, you can only use diuretics when your sufficient turnover osmotic pressure is present in your blood vessels. So even before you start on diuretics, you have to ensure that the patient has sufficient level of serum albumin and globulin. Otherwise, you will not be able to reverse the shock that the patient is undergoing and you will lose it all. That is the beauty, that is the seriousness of these simple blue lines which people fail to appreciate. One day you will be standing there and you will be remembering. The sir told us that such a small difference can cause life or death situation for you. MI, old MI, IHD, ischemic heart disease, CVA patients, what do you give? You give anticoagulants. Okay, you give anticoagulants, and major anticoagulants work on potassium dependent coagulation factors. Warfarin. Okay, warfarin. This is why you have PT, MBTT, INR, activated thromboplastin time, close thrombin time, and international normalized ratio taken in order to ensure whether the patient has sufficient clotting ability. In case of a damage, in case of a cut, you will not lead the patient to a severe blood loss. But if your liver does not have the capacity to produce prothrombin, then only way to manage is via platelet transfusions and fresh frozen plasma transfusions. Otherwise, even a simple injury, the patient will bleed to that. It will just bleed to that, you won't be able to do anything. Okay? That is how it works. Focus of your hepatocellular injury. As I said, each and every anatomic niche will have each and every specific cell, and this ALT, alanine aminotransferase, and aspartate aminotransferase is present in your hepatocyte, inside your hepatocyte. Then the obvious question is that when you are taking general blood, we are seeing HTN. Validate transform, it is supposed to be inside the cell, right? It is supposed to be inside the cell, no? So how come it is reflected in blood? You have heard the terminology isoenzymes, right? Yes. You have heard the terminology isoenzymes, right? You have heard, no? And a particular amount of hepatocytes will also decrease in due time. Everything comes with an expiry date. Okay? Only when the damage is normal and within acceptable levels, that is your normal reference level for your ALT and AST. This will only increase in pathological portions or at interventional portions when there is an ongoing injury. Okay? So, first group pointer was, group 1 was conjugated and unconjugated. The second is your alanine aminotransferase and aspartate aminotransferase, which are the marker of hepatocellular injury. And finally, you have markers of cholestasis, that is alkaline phosphatase and lava glutamine transferase. How many isoenzymes of alkaline phosphatase? 5. Okay. Will be asked, you cannot get rid of alkaline phosphatase, you cannot get rid of LDH. These isoenzymes will be asked in your examinations. Okay. Please know which isoenzyme is present where and how they are utilized in diagnosis of disease states. What are the limitations of AST? Liver has a huge capacity. I often find plenty of patients have got a normal routine and may get diabetic for 2 years. AST 30, ALT 140, such great take medicines. Sir, is my liver in any kind of danger? Sir, sometimes in parties I do drink one kind of medicine. Is my liver in danger? Is his or her liver in danger? AST 30, ALT 140, which is supposed to be 30 to 50. No! Liver has the largest capacity. Okay? Liver has the largest regenerative capacity of your entire organ system. Okay? Asymptomatic people may have abnormal results. No symptoms. in albumin normal. Okay, get appendicular. Okay, abdomen total albumin and globule. Abdomen, very good. No, because there are other organ systems which also play a crucial role in meiosis. Okay, so mainly use liver function as a test for assessment of patients. That condition which goes on along with treatment, whether it is deteriorating or whether it is getting better. LFT is not a diagnostic tool. For diagnostic purposes, we have far better options than urine. Okay? To put it in short, alanine aminotransferase, hepatocellular damage, aspartate aminotransferase, hepatocytic damage, bilirubin, cholestasis, impaired conjugation, or there is some obstruction, in the bile pathway, prothrombin type, synthetic function, blood clotting function, albumin, synthetic function, maintenance of hydration of blood space and medium, gamma glutamine transferase, cholestasis or biliary obstruction at the site of large canalicular. Okay, at the site of large canalicular. Bile acids, cholestasis or biliary obstruction at hepatocyte itself. Okay, so these are your common serum liver markers and these are your clinical indications if they are at ophthalmological level. Now let us come to bilirubin. Byproduct of RBC destruction. Yellowish pigment. Bilirubin is yellowish, bilirubin is greenish. Okay, and you will see it in jaundice. Pantu Raja পাইছিল God Dhritarashtra পাইছিল. He was supposed to be the king. Unfortunately, liver disease, likely Biglar-Dajar syndrome, Bichara died very early, so his brother had to take over. Okay. When will you see high bilirubin levels? Gallstones. Can gallstones give high bilirubin levels? No. They will only give high bilirubin levels if they break down and come out of your gallbladder and get stuck in your common hepatic duct or common bile. Otherwise, it is not supposed to cause. Gallbladders are not supposed to cause jaundice. Okay, keep it in mind. Lifelong lesson. USD, stone in gallbladder, sludge in gallbladder. Patient is not supposed to have jaundice. If you have in that circumstances increased liver enzymes, increased AMP, then think of pancreas. Singular gallstones will never cause jaundice. Are we clear on this? Yes or no? Single gallstone, only gallstone, they cannot cause jaundice. Pathway to be liver to go to bile tubes. Gallbladder comes as cystic duct. You have common hepatic duct coming from there. Gallstone is present in that pocket only. You see, this is your liver. This is your liver. This is your gallbladder. Okay? From here you have right common hepatic duct, left common hepatic duct to form common hepatic duct. This common hepatic duct will join with your cystic duct to form bile duct. This bile duct with like this. Okay, it will form hepatomeningeal. So here the stone is here. Is there any obstruction in the pipelines? Yes or no? So singular gallbladder is never used. Whenever you see jaundice in a gallstone, think of pancreas, think of common bile, think of cancers, but never your gallbladder. Then we have, I have seen these, I have shown this thing also. So this is your what system? What system? What pathway? You had shown this, right? Bilirubin pathway? So in that, that is your heme, your hemoglobin. Hemoglobin will break up into heme and globin. Where will globin go? Globin is one of the other proteins. Globin is an intrinsic part of plasma proteins. It is globin and albumin are the universal chelators. They are the universal chelators. They are the universal acceptors that allow different things to be carried via blood. Okay. So then when your RBC breaks down, then you have hemoglobin. Why it is happening? In your macrophages. Okay. Macrophages of what system? Reticular endothelial system. Such a good name, reticular endothelial system. Reticular endothelial system. What is reticular endothelial system? Bhai chapni. Reticular endothelial system is a sieve. Akka chapni. Old RBCs more than 120 days, they lose their elasticity. Can I match the elasticity of an 80-year-old kid? I am 32 years old. Can I? Yes or no? I can. I am so thankful, man. You are the only person who has supported me so much. I am so happy. But I will not be able to. That is the truth. Okay? So when they get fixed shape, reticular endothelial system acts as a sieve. They get caught in there. And the fresh RBCs, 20 years old, 20 days old, 30 days old, they will wriggle past it. And the fat old ones, they will get caught when we are eating it. Okay? Now what these macrophages do, they engulf them, they break it down. Get it? Now you will understand what reticular endothelial system is. Will you forget? Will you at least try to forget? At least try to forget, but you will not be able to. Reticular endothelial system is a sieve, ওটা একটা ছাকনি। ওই ছাকনির মধ্যে পুরনো যেগুলো শেপ ফিক্স হয়ে গেছে আরবিসি গুলো সেগুলো আটকে যায়। যেগুলো নতুন যাদের ইলাস্টিসিটি আছে তারা ডিগল করে বেরিয়ে যায়। ওকে? And once they will enter your macrophage. Okay? They will enter your macrophage in your spleen and liver. Okay? Spleen and liver. Let me go to the next example. See, hemoglobin, heme. From heme, there will be bilirubin. Come on, I will give you. Don't do it. I get irritated. I will not teach you anything. I will just come out of the car. I will give you the entire presentation. Why do you need to take out your cell phone and irritate? Okay, so heme, bilirubin, unconjugated bilirubin. I just told you albumin and globulin are your first class chelators. They allow everything to travel via blood. See, albumin is there. Chelating unconjugated bilirubin. This unconjugated bilirubin will go into liver. They will go into your hepatocyte. In hepatocyte, what enzyme do you have? UTP. Glucuronide transferase. Okay, that is a conjugating enzyme. UDP, glucuronide transferase, the universal conjugating enzyme. Okay, what will you do? They will put unconjugated bilirubin into bilirubin monoglucuronide and bilirubin diglucuronide. Why do you need it? Why do you need bilirubin monoglucuronide? Why do you need bilirubin diglucuronide? Why do you need it? You must leave that extra atom back to the blood. It has got other people to catch. from the ATM to collect your food and come to your room. So for different purposes, for different areas, they have different. Just like your purpose. Okay. So now we have bilirubin, triglyceride, which is actually soluble in water. So your albumin goes back to catch rest bilirubin. So happy. You can always catch rest bilirubin. Okay. Don't try this at home. Might be life threatening. Okay. So now this bilirubin triglyceride will be passed through your common bile duct to the intestines. What is free in intestine? Intestinal flora. What is free in intestine? Intestinal flora is free. Freeloader. Is it a good freeloader or is it a bad freeloader? Of course, it's a good freeloader. Of course, it is a good freeloader. Okay, it helps you digest so many things. It helps you digest so many things. So that they will break a part of your bilirubin to your urobilinogen. And this urobilinogen from your liver will go back to your intestine again to form bile salts. You are using these bile salts to liquefy, to break the miscellaneous of fat so that you can absorb them. When the function of this bile salt is done, they will again be reabsorbed in the liver. And this gol ghumna or chakkar lagana of urobilinogen and bile salts is basically your enterohepatic circulation, which comes as a short note for 3 marks in your university examination. So if you know the concept, then you know why that circulation is there. Then you know where it starts, where it ends. Does not matter whether you have burnt the midnight oil, you can always write a proper answer. You can even draw this diagram. Okay? So make things easy. If you have the concept, you can definitely write something. So there goes your enterohepatic circulation. Finally, then your rest of your conjugated bilirubin will become urobilin and scapupobilin, which give color to your stools. That is why if you have obstructive jaundice, then your stools will look like that of a cat stool. Plain, white. It will not have this beautiful vibrant yellowish tinge. Okay? No, that is bread and butter for pathologists and biochemists. We have to see it, we have to report it, so don't wish. Might be someday you will land in the other side of that tree and then you will say, Bhagwan, aaj kam se kam 40 go school bhej de. Increment nahi ho raha, 3 mahine se. Okay? So, this happens. Okay? So, this is your metabolism of bilirubin in short. This is the place where each and every fiber will start. This is the place where each and every fiber will start. So be here and repeat after me. The normal bilirubin levels or total bilirubin in blood is 0.2 to 0.8. How much? 0.2 to 0.8. Okay? What for unconjugated? It is from 0.2 to 0.7. Repeat. 0.2 to 0.7. Obviously, if unconjugated is 0.2 to 0.7, then conjugated will be 0.1. Likely 0.1, but still due to physiological variation, it can go from 0.1 to 0.4. Please repeat after me. It will go from 0.1 to 0.4. That is for your conjugated bilirubin. And then comes your latent jaundice. Latent jaundice means jaundice felt in the blood reports, not seen on your face and arms. The level of that is more than 1 mg per dl. Latent jaundice is more than 1 mg per dl. Okay. Total jaundice is above 2 mg per dl. Jaundice is above 2 mg per dl. That does not mean that there is an ongoing pathology. Jaundice more than 2 does not mean ongoing pathology. There is a concept called physiological jaundice. Can anyone of you name physiological jaundice? She came to the class for Toto, that's why she is all right. I saw her coming. My Toto. Oh. Okay, that's why she is not being able to answer anything. She is lost in the wings. Okay? Have you heard of menstrual jaundice? Neonatal jaundice. See, what happens is, when the newborn child is everything alright, my boy? You are sad? Everything okay? You are feeling right? Okay? See, in case of a newborn, the conjugation system is sometimes not mature enough. So the mother will feed breast milk. The boy will develop jaundice. Bilirubin levels more than 2 gram per dl, 2 milligram per dl. The kid is like having suppose 6 gram per dl. And you are the unfortunate resident pediatrician. Patient will come and say, Doctor साहब मेरे बच्चे को क्या हो गया तो फीला बोल गया क्या होगा? What will you do? That's going India in China. Simmering चला दो. Phototherapy दे दो, है ना? Right? And after that you get things back and blue because it is physiological jaundice. You are not supposed to do anything. This is going to take 1 hour within 14 days. Clear? What about physiological jaundice? You see my liver is red. Now you feel my liver is red. So everybody please love your livers. Okay? In case of physiological jaundice, do not do intervention. If you get caught, God help. Okay? Now these are the normal bilirubin levels. Then we have prehepatic or hemolytic. Prehepatic or hemolytic. That means your RTCs are getting broken before they reach liver. Then the RTCs are getting broken down in blood vessels. Blood vessels, RTCs are getting broken down. This is called intravascular hemolysis. This is called intravascular hemolysis. Okay? See, abnormal red cells, thalassemia, hemoglobinopathies. Can you name some hemoglobinopathies? Physiology people are so happy to talk about obesity. You know, they're so happy to talk about obesity. Hereditary spherocytosis, hereditary electrocytosis. There are n number of lists. Co-agglutinogens, quad-agglutinogens, antibiotic inflicted, genetics starting from thalassemia to sickle cell anemia, each and every one of them is prehepatic, hemolytic. Okay? So, and the most important here, what I actually need to teach you is Gilbert's sacroiliac measures. So there is a topic which is called congenital hepatic congenital hyperbilirubinemia. I use this term hyperbilirubinemia because it may be conjugated also, it may be unconjugated. Okay? So, what is the topic? Genetic congenital hyperbilirubinemia. 2 classes. I think I should rather use the one. You people are looking at me like owls. Congenital hepatic hyperbilirubinemia. Gilbert syndrome, Midler-Naja type 1 and type 2. Gilbert syndrome, Midler-Naja type 1, Midler-Naja type 2. And unconjugated is doctors are TR. Tubin-Johnson syndrome. Tubin-Johnson syndrome. And there is Rotor syndrome. Rotor syndrome. Now, 2 years back, all the hepatic congenital hyperbilirubinemia are autosomal recessive except all of them are autosomal recessive except Rotor. Okay? Rotor has the only one which has an autosomal dominant predisposition. It is also basically autosomal recessive, but it has an autosomal dominant predisposition. Come on guys, it's a deep question. It is not your internal assessment. So it has a sound. Okay. So please remember that. Maybe you will find it. You have got 30 minutes. Okay. So now this Gilbert and Midler-Naja, both of them are unconjugated hyperbilirubinemia. But say UDP glucuronide transferase enzyme is not produced properly for a genetic defect. The name of the gene is UCAT1A11. Okay? UCAT1A11. Same gene, same enzyme. Same gene, same enzyme. One disease is being called Gilbert, another is being called Midler-Naja. Right? Same gene, same enzyme. There should be one disease. Why should we identify two? Questions नहीं बनता है. एक चीज है, एक और दो डिजीज क्यों बनेगा? एक ही डिजीज बनेगा ना? नहीं, दो डिजीज बनेगा. So there are two different mutations. There are two different mutations. Now the funny thing of Gilbert and Midler-Naja type 2 is they are very transient. They are not found clinically. They are found accidentally. A patient comes to you, recurrently you are giving patient medication, he always comes up to you with unconjugated hyperbilirubinemia. That means unconjugated bilirubin at the levels of 50, 20, 30, never going below 20. This is the case of a pathological condition where you do not need any intervention. That is your Gilbert syndrome and Midler-Naja type 2. In Midler-Naja type 1, it is a very severe condition. There is not at all presence of UDP glucuronide transferase and the patient does not last long. They usually pass through. Okay? That is your Midler-Naja type 1. Now comes your Tubin-Johnson syndrome and Rotor syndrome. Both are basically channelopathies. Do you understand the terminology channelopathy? You see, each and every cellular function is done via channels. You want to take in sodium, you want to push out potassium, sodium, potassium, ATPase, that is a channel. So here both of them are also basically channel channel proteins. For Tubin Johnson, it is MRP2 protein. MRP2. Okay? This protein gets mutated. That is why the biliary canaliculi is not able to absorb conjugated bilirubin from your hepatocytes. So it goes back, the conjugated bilirubin goes back and increases its level in liver. Got it? See, the amount of space in hepatic canaliculi are fixed, in hepatocyte is also fixed. The hepatic canalicular cell through MRP2 protein is supposed to absorb conjugated bilirubin, right? Now if this passage is blocked, up till a volume that will be there, then the rest will spill into blood, right? And that is what is causing congenital conjugated hyperbilirubinemia. So Tubin Johnson and Rotor are basically channel abnormalities or channel defects. Okay? This each and every alternate year appears as a shock. Okay? Hepatic congenital hyperbilirubinemia. You will definitely be asked if you get a chart of LFT during your practical exam. Please go. Okay? Please go through it. You have to. Miss it at your own time. Okay? Then you have hepatic or hepatocellular. Viral hepatitis. Mainly hepatitis A, B, C, D and E. Which are waterborne? Which hepatitis are waterborne? Hepatitis A. Rest are bloodborne. Rest are bloodborne. Okay? So, viral hepatitis and there might be toxic hepatitis. Mainly poison cases. Mainly poison cases. Okay? They cause hepatocellular jaundice. And then finally, closed hepatitis. That means there is obstruction in the pathway. That is either cholestasis or gallstones or cancers like carcinoma made of pancreas. Urobilirubin, I have already told you. Okay, it is not a parameter in the liver. It is supposed to be disseminated in your urine. Finally, serum albumin. Serum albumin levels are 3.5 to 5. 3.5 to 5. Okay, and this is your total serum albumin level, and your total protein levels go from 0.6 to 0.8. So your albumin levels is just half of it. Okay, it will be half of it, and the AT ratio should always be 2:1. Okay. So with this, we are done with your LFT. Doubts as a question. Definitely unconjugated hyperbilirubinemia will come as a short note, and it will definitely fall into charts. Okay, that's all.
What is the knowledge of thyroid from the plant? Our school level. What is the function of thyroid? Function of thyroid. Main what we know is it is metabolism. Main function is metabolism. Regulates the O2 consumption by the tissues and the metabolism. So is it essential for life? Yes. So if there is no thyroid, surely it will be fatal. Many elders in our home, in some cases in young age also, hypothyroidism develops. That is either is not fully deficient usually. Hypothyroidism is decreasing thyroid levels. So many of us, many people, it is a very common thing due to iron deficiency. So thyroid hormone for thyroid hormone synthesis iron is equal. This must be all known. So due to iron deficiency, many people, large part of the population, large means at least a part of the population in our country, still now this knowledge is not existent that iodine salt must be taken, etc., etc. Iodine salt must be used. So iodine salt is a good source of iodine, and iodine there are other sources. What are other sources of iodine? This is not today's topic, but arterial. So your tendency has become to sit at the back, not to participate in the class. एक क्लास में पूरी जाओ because बैच में होने का है आप उसको सेव खुद से ना सेव हो जाए ना ये मेंटेन करना है वो इंटरेक्शन नहीं जिनको आने के लिए फिनिश तो सेक्टर को डायरेक्ट से कॉल है सी फिश आई कॉल है সবাই তো ফিশ এখন তো এমনি মোর সো ইন आवर country hypothyroidism is very common. It is found in, if you see, when you become doctors sitting the OP for one day and examining 30 patients, maybe one or more will be hypothyroid. And it is common. But it is not essential for life. Like the program, the book you diagnose, it is not essential without the person remains hypothyroid, you are simply not dying, but the quality of life will decrease. If there is congenital hypothyroidism, this is a lead here. What are the effects? So every hormone, what are the broad readings? What are the learned in every hormone? Almost every hormone, not the pituitary one. So pituitary and hypothyroid releasing hormones. And stimulating hormones of the pituitary, releasing hormones by hypothalamus, stimulating hormones by the pituitary. Basic characteristics of the endocrine physiology, you know, by the pituitary axis, names of all the endocrine glands. Okay, what are the hormones secreted by appendicular and posterior pituitary level? That is the names. And cells will secrete them. Cells will secrete them. We have to from that to memorize. There is no other option. Some things you must memorize. So what are the thyroid hormones? Names of the thyroid hormones? T4, T3 and so which is more abundant? T4 and T4 or T3? How many for T3 and how many for T2? This is the problem. Why I am telling come forward and what about this is the problem. It is not that only you are voting for people. Most of you don't want to answer. Then this becomes a problem with the Viva examination. If you sit quietly during the Viva examination, then if you answer what you will be scolded, but you have a second chance. The examiner will ask some other question. But if you sit quietly during the Viva examination, some examiners prefer that they will take 3 or 4 people together. So maybe only one is answering and the other 3 are almost silent. কোনো সময় এত বার ওই সময় থেকে সব আওয়াজ বন্ধ হয়ে যায়। মুশকিল হচ্ছে কখন আর কোনো মার্কিং করা যায়। খুব সিনিয়র এক্সামিনার হলে সবাইকে পাস মার্কিং ছেড়ে দেয়, কিন্তু বেশিরভাগ এক্সামিনারটা করে না। And repeating that we had to just almost like to use the term base, ये মানে मास पिकअप करते हैं this is almost like our economic so at least you get which is more either T4 or T3 and do you know there is something called reverse T3 এটা নাও জানা থাকতে পারে there is something called reverse T3 so thyroid hormone and I at least both types of it is not a very home method colorful pictures and all that but I don't know because they some cases that takes a, some of you are interested that takes a that. Some of you think that the teacher is coming, not studying himself or herself and just showing the PPT, copying it from the book. So that is more, some cases that does not change. So I do not use that. You may not know the structure at all, but basic things to T4 is more abundant. Wherever T3 is, but more active is physiological effects like T3. T4 is more abundant, but physiological effects like T3. So T4 is converted to T3 by T4 has 4 ions in the structure. 4 I, which is the structure we write as I. And T3 what? Deiodination of T4 one time will convert into T3. That is the peripheral conversion. Most of it in the circulating, first of all, in the circulating blood, that is in the circulation. And in the circulation, most of the thyroid hormones is T4, and most of it, almost, it is not 100%, it is more than 99% is bound to some protein. Whatever is free hormone, that most of it is T4. Very less amount of T3, that is by the peripheral conversion of T4 into T3, that is deiodination. One iodine taken away from T4 from a particular position. Detailed structure we don't have to know, but thyroid hormone is. So hormones, if endocrinology, basic endocrine physiology has been done, what are hormones are chemically classified into what type? Hormones are either this type or this type, steroids and peptides. This much you should know, you are maybe within 2 weeks in a week or either steroids or peptides. Okay? So steroids or proteins. Proteins are either peptides or amines. So thyroid is it is derived from the amino acid tyrosine. What is this? Now, our lesson is not to the level of creator. Basic, I was from higher corporate program, you should know better organizations than मोटा हो गया तो छोटा सॉरी अदर वन छोटा एक टाइम में आप जस्ट बेसिक इट विल हेक्सागन मोटा डायग्राम सो इंटरेक्शन बोले we बोल रहे you will say that sir অ্যারোমেটিক নিয়ে চারটে কাটতে তোমরা তো সবে পড়েছো ছটা সো দিস ইজ দা এবার টাইরোসিনের এখানে যখন থাইরয়েড এখানে আবার আছে এখানে একটা এটা কাটলে কটা হাত there is four hands this is one two one এইখানে বলতে দেখতে পাচ্ছ সিওএইচ একটা here is the aromatic ring. Now can you see those who are at the back and still saying come forward. Take something from the class and interact with the teacher. Lecture classes are gradually becoming obsolete when NXT stage. Now there is a class called lecture motion in your this curriculum called HG. Do you know that? Due to some reasons we have lessened the hours because no one used to come in the last class. HGD class no one is attending. It has even happened that there are 4 teachers sitting in our department and only 2 students are what to have 2 p.m. to 4 p.m. So this time we have done that anatomy department was studying that they are also facing problems in this dissection classes 50 students on one day, next day same topic 50 students, 50 students. So 150 same at the same time 2 p.m. to 4 p.m. and we continue class. So for your batch it has been changed and practical and STD has been but STD is required all group discussion 4 or 5 people you have to read this topic. Questions will be given, you have to discuss and there will be a group discussion with the teachers. There will be 2 or 3 teachers. So we are available. But you put it as a laser hour. You not that is the last time. So no fruits of that. So we have anatomy department. So dissection class is now going on. Monday to Thursday, 2 to 4. And yesterday is in the practice. HOD sir is teaching neuromuscular physiology. What are we going to start to do fast? Which are respected to that skill of activity. So you should interact. Is basic. এটা তো মানো আপনি অর্গানিক বেস অর্গানিক বেস উপরে ডায়াগ্রাম লাগবে ডায়াগ্রাম হবে না অ্যারোমেটিক দিয়ে 6টা কার্বন থাকবে সেটা তোমার সঙ্গে সঙ্গে পয়েন্ট আউট করো So dialysis, it is a part of which molecule from which thyroid hormone is synthesized? It is a part of synthesis and secretion of thyroid hormone and synthesis of thyroid hormone is a broad process. মানে like GI তে যেটা এসেছিল ডাইজেশন তাও লিখতে পারো এত বেসিক ব্রড কোশ্চেন আসবে সিম্পলি ও তার ভালো করে লিখতে ভালো করতে হবে আলটিমেটলি মার্কস ইজ ইম্পর্টেন্ট নলেজ ইজ নট ইম্পর্টেন্ট we all believe that in this era নলেজ দরকার নেই নম্বর দিয়ে দেখাতে পারি সো মার্কস পাওয়ার জন্য যদি পড়াশোনা করতে হয় তাহলে সিনথেসিস অফ থাইরয়েড হরমোন লিখতে হবে ব্রড কোশ্চেন these are basic প্রত্যেকটা চ্যাপ্টারে একটু মাস করে দেওয়া হয়েছে সিনথেসিস অফ থাইরয়েড হরমোন মাস সো দিস ইজ আ পার্ট অফ thyrosin part of thyroglobulin molecule now how the coupling and etc will occur will come in that so basic structure of thyroid hormone where it is located আরে কিছু তো বলো where is thyroid hormone located কোথায় located না from where what is from the হয়ে গেছে thyroid anatomy হয়ে গেছে thyroid হয়নি so embryology কোথায় so in some cases there is a persistent thyroid duct even in adult life thyroid duct from the marks the position from the base of the tongue to the nape where the thyroid is located and it is a sterile organ that is present on the 2 sides of the larynx and there are 2 lobes connected by the isthmus okay one thing about except metabolism this is the main function what is the other role of thyroid hormone it secretes what except thyroid hormone it secretes what something called calcitonin which will aid in calcium metabolism has been started calcium metabolism that is a very important factor on Saturday it has been started so calcitonin regulating the level of calcium in blood that is calcitonin is secreted by the thyroid gland. So that will come along in calcium metabolism. We usually discuss calcium metabolism. Here we discuss about the thyroid hormones T3, T4 and another is artery. So T3, T4 and reverse T3. R3 is reverse T3. So your thyroglobulin is from what thyroglobulin everything is in the thyroglobulin in the interior of the cell. So thyroid structure, basic structure, histology the thyroid is. So have you seen the histology of histology is follicles. There are secretory follicles in the thyroid gland. How do we do? So these are the secretory follicles. When it is inactive, they are smaller in size and bounded. Flat cells surrounded by flat cells. These are the thyrocytes. That means thyrocytes. Here is the inside is the colloid epithelium where that thyroid protein is present. এটা যখন অ্যাক্টিভ হয়ে যাবে, this is the when the gland is inactive. That is the gland is never altogether inactive. That is the inactive portion of the gland. The follicular cells, the follicles should look like spherical shaped follicles. And of the order of the cell, what are sitting the thyrocytes, the other of the follicles, they are lined by flat cells. Flat cells in tissue histology, tissue squamous cells, and it becomes cuboidal or columnar when the gland is cuboidal, spherical. এরকম হয়ে যায়, একটু বড় দেখায়, cuboidal or columnar cells. এরকম থাকে। And what so if the surrounding what will happen, it has to transport iodine. So across the thyrocytes, iodine will be transported to inside the follicles. Iodine is required for synthesis of thyroid hormone. Colloid thyroid hormone, basic tyrosine component, tyrosine is here. So tyrosine, now iodine will be required for the formation of thyroid hormone. Okay. So this is the basic structure. Thyroid lobes connected by isthmus. One function is secretion of thyroid hormone, major function. Another is secretion of calcitonin. So major function is regulating metabolism, and another function is secondary function is regulation of calcium levels in the blood. And now this is the structure follicle, thyroid follicles, numerous follicles. In inactive state, follicles which are in inactive state at a particular time, they will be smaller in size, surrounded by or lined by flat cells, looking like squamous cells. And whenever the which cells are synthesizing and secreting, they are lined by those cells. They under the microscope they will look like columnar cells and cuboidal or columnar cells, and the follicle is also increased in size. Now what happens if this is the inner part of the cell, that is the outer part. So this is the thyrocyte. One thyrocyte here. So this is the thyrocyte. Now, iodine has to be transported from one side of the cell towards the colloid, right? Iodine has to be taken in. Major source of iodine inside the thyroid is already, we are talking to that already. Whatever iodine is absorbed, that is recirculated. Now, even if what makes an iodine deficient in a normal human being who was producing, whose iodine intake was normal, say at about this point of time, and thyroid hormone secretion and synthesis was normal. Even if iodine deficient diet is taken on for continuous 2-3 months, then also thyroid hormone synthesis and plasma levels should be maintained. Because once iodine is taken in, it is recirculated. Why are you talking? Even if you take iodine deficient diet for 3 months, 2-3 months, 2.5-3 months, they also thyroid hormone plasma levels should be maintained, because once iodine is taken in, it is recirculated. If I have 500 iodine, of course, excess iodine, one equilibrium of thyroid hormone synthesis is Excess iodine also hampers. Deficient iodine will obviously hamper thyroid hormone. See, if you don't like, you may go out. Attendance to wait. একবার তো বললাম তারপর আসছে you don't like the class you may go out. One deficiency of iodine will obviously hamper thyroid hormone. But what it means excess iodine also hampers thyroid hormone. So how iodine is balanced, you don't have to know the actual numbers. Say almost 500 milligram of iodine is taken in the diet every day. How it is balanced, how much is metabolized in the liver, how much is metabolized in the kidney. Those exact numbers you don't use even in higher in the standard textbooks. You don't need those. That is balance of this iodine. How is iodine metabolized? Iodine metabolism, how much is metabolized in the liver, how much is the kidney, how much is excreted to the kidney, that is in urine, how much is stool. Everything there is a number, maybe minor amount is excreted in the stool level. And itself the hormones are also metabolized and excreted from the body, but you don't have to know the exact numbers. Not required, but just know iodine is balanced, but iodine which enters the thyrocytes, that is the colloid portion through the thyrocytes, even if the cell follicle goes into the inactive state and iodine is stored there in the form of something called MITTIT. We are coming to that synthesis. So it is stored there, and even if after 3 months also, if the for 3 months continuously the iodine deficient diet is taken, plasma levels of thyroid hormone and its functions will not be hampered. Okay, plasma levels will not fall, it will be maintained and its functions will not be hampered. So it enters, iodine enters the, so general physiology is done. So you must be knowing this term, sympater antidote. Iodine enters the cell through sodium iodide sympater. Sodium is also entering and iodine is entering together. Sodium iodide sympater. Okay, that is from the outside of the thyrocytes, and it goes inside the cell in extent of inside the cell. Sorry, you should not say inside the cell. Thyrocyte in itself was here. It goes inside the colloid where the thyroglobulin molecule is present. Iodine is incorporated into the thyroglobulin in extent of chloride. That is sympater antidote. Different directions, but that is usually we do not call it the classical antidote. It is sodium iodide sympater. Sodium iodide sympater is present. Iodine is then incorporated into the thyroglobulin in extent of chloride. Here it is called the pain. Here it is called the pain. This pain is assisting in the incorporation of iodine in exchange of chloride. So sodium iodide sympater iodine is entering the thyrocyte. This is the thyrocyte which is lining the chloride, the molecular lining which is lining the outside of the chloride. So thyrocyte, sodium iodide is sympater, iodine is taken in and incorporated to the thyroglobulin by the means of the pain in exchange of chloride. Okay. So if you have tried about synthesis of thyroid hormone, you start from here. Iodine incorporation into the thyroglobulin. First sodium iodide is sympater and then exchange of iodine and chlorine. There are various things, I think your textbook whether it's in there, but there are various other things to go about this. But this much you should at least write that. So at core level sodium iodide sympater and MBBS mentioned and you write the incorporation of iodine. So first step is how is iodine taken in by the thyrocyte into the follicle, thyroid follicle. see in the aromatic molecule, this is the first position, second, third, fourth carbon, fifth carbon, sixth carbon. Okay. So we will concentrate on 3 and 5. Why? Because I am explaining this. We are concentrating on third and fifth position, third and fifth carbon of the tyrosine molecule. This aromatic ring tyrosine molecule, we are concentrating on third and fifth position because when these two molecules will condense, iron will first be attached at this position. Okay. Incorporated to the third iron will attach to the tyrosine at this position first. Third, only 3. Then it will be attached to. Before that, right? It will be attached only to 3. What is called attached only to third position. Monoamino tyrosine. While only attached. So simple. This is pretty simple. We are not going into detailed structure even if you don't like to remember this amine NH2COH. This is simple, but if you don't like to just this much you can write CH. That is NH2, that will be COH. Carbon atom 4 hands. So one hand will be attached to the aromatic ring. One is hydrogen atom. One is NH2. One is COH. So even if you don't like that. Just concentrate on the aromatic ring and third and fifth position. Third position, this is 1, 2, 3, 4. So in the third position, if the iodine is attached, it is converted to MIT, monoamino tyrosine, single iodine. Now next iodine will be attached here. So both 3 and 5 it becomes DIP. So in the colloid, simple. Everybody understood. That those who want to understand understood. After one iodine will go and attach to third position of the ring and another to the fifth position of the ring. Now in some molecules should be there. Just that will be just MIT. Only one iodine will be attached. That is MIT because all these will be required. MIT will be required. DIP both will be required for the formation of. So there are few molecules only attached to the third position. Few molecules of tyrosine were attached to both third and fifth position. Only fifth it will not happen. First it will attach to third. And if DIP will be formed, it will not happen. Remember this that only attached to fifth position without attaching to third. That will not happen. Chemical reaction will not occur like that. Why? You don't know. That is not our concern also. It will be attached to third position MIT, monoamino tyrosine. Attached to fifth position it is DIP, diamino. So now see this thing. T4 is there will be 4 iodine atoms. So what is 3' and 5'? Another similar ring and those. What is 3' and 5'? See T4 I will get iodine in 4 positions. Which 4 positions? Third, fifth, and other 2 positions also third and fifth of the another molecule. Similar molecule. Another similar molecule. Third and fifth. Can you follow me? Third and fifth position of one tyrosine molecule, third and fifth position of another. Now for the second molecule we are giving the names of third and fifth, 3' and 5'. For P3 it will be 3, 5 and the will not attach to the, if another molecule incorporates iodine, it will not attach to the fifth position first, it will be attached to the third position. So 3, 5 and 3 dash. Iodine is present in 3, 5 and 3 dash. 3 dash means this thyroid hormone will be produced by the condensation of two such aromatic rings of tyrosine. কোথায় আপনি সেটা এক্সেল আমার so formation of MIT and DIT you could understand now see এইটুকু লিখবে just to understand that this is first position. Then you can understand কিছু মুখল as long as we go try to memorize we take to 40. So even if you don't write that CH it will also do, but then you have to remember which is the third position. So you write that CH that is 1, this is 1, then you go and this is 2, this is 3, this is 4, and here it is OH, okay? Draw this is 4, this is 4, this is 5. So the fourth position is OH is attached. So 3, 5. So may not write this. This way is OH. So this is 1, this is 2, 3, 4, 5, 6. Now when condensation happens, now MIT, DIT have understood how it is formed. Monohydrotyrosine and dihydrotyrosine. Now if 2 DIT is condense, 2 dihydrotyrosine is condense, then what will be formed? T4. Now I will condense, this will be T4. This is another aromatic ring. So this is 1, this is 2, 3, 4, 5, 6. Now this second molecule we name the positions with the dash against the number. Now you have understood. There will be various other things in the there with the double bonds. In the aromatic ring there is the against the 3 carbon atom there will be double bonds. I am not drawing anything extra which is not required to understand the structure of the where the iodines are used. Just to concentrate where the iodines are being attached. So T4 is iodine is present in all the positions. T5, 3'5'. This is T4. Understand? So this reaction is called coupling reaction. Two DIDs are being condensed to form T4. This is the coupling reaction. Okay. So there are two observations or two opinions how this coupling reaction occurs. Some are telling that this DID and before that I tell mention this will be easier if we can understand two DIDs are condensing to form T4. Then if one DID and MIT what will be formed? T3. So that will not contain will be T3 will not contain this iodine. 5 plus iodine. You understood because iodine will first be attached to the third position, not the fifth position. If 2 iodines, then third and fifth. But if only 1 iodine to the third position. So if T4 was the previous one, T3 is this one. T5, T dash. You got it? H is simple to aromatic ring, iodine will be attached to either 3 or 5, but not 5 alone. If it is single iodine to 3, third position, if 2 iodines to 3 position, single iodine attached to third position forms MIT, monohydrotyrosine. 2 iodines attached to 3 and 5 positions forms dihydrotyrosine. 2 dihydrotyrosine molecule condenses by means of the coupling reaction. to form T4, and if DIT and one MIT, then it is T3. Then in one of the rings it will be obviously to the third position only, because allowed position is not possible, right? বুঝতে পারছো? This is a broad question. এটা একদম straightforward question. Synthesis of thyroid. Synthesis and secretion are two number thyroid secretion আমরা synthesis every hormone you have to learn. Most of the hormones you have to understand except the synthesis secretion from where it is secreted. Synthesis secretion, physiological functions or physiological actions. See your complexes. In our days, there were no such complications made by the medical profession. We didn't know, even the teachers were worried that what to teach and what not to teach. Now, in NCS, divided into complications. The physical synthesis, secretion, physiological action, and effects of decreased level, increased level. That is hypo and hypothyroid, hypothyroid. What are the effects of hypothyroidism, hypothyroidism? Any clinical correlation, that is any clinical physiology is that. What are the clinical terms? Some clinical terms you have to learn, and physiological action. So here synthesis of thyroid, abdominal hormone synthesis of this question is usually not given. Synthesis of thyroid hormones is the straightforward question. So first we started from how artery is incorporated. Next is this. So this complete. So T3, T5, T'. And what is RT3? RT3 is, that means in this position I will not be present. That means in the first molecule, during condensation, when the second molecule is coming, this second molecule is DIT. First molecule is MIT. That means condensation of DIT into MIT forms RT. Very minute amount. Very basic amount. So mostly produced is T4, some of it is T3, and most of the physiological effect, which is the hormone which is producing most of the physiological effects of thyroid hormones, T3 or 4, 3, but which is the most abundant in that is abundant in the terms of how much it is contained in the plasma in the circulation, that is T4. Okay? And RT3 is very minor in amount because T3, that is DIT is going and condensing into MIT. So DIT is 3 at third and 5th position. Second molecule, we will add a dash to the position numbers. 3' and 5' is RT3. 3, 3', 5'. First molecule MIT obviously at 3 because abdomen position is not possible. Understood this? T3 RT3. Now this complete reaction, there are two opinions how this is occurring. One opinion is within the thyroglobulin molecule itself, this complete reaction is taking place. Just write this. In the standard textbook, one opinion is even in standard textbook it is written exactly like this. That is, complete reaction is occurring. Two DITs are condensing where itself inside the thyroglobulin part. And one opinion is saying no, DIT is separating from thyroglobulin, another DIT or MIT is separating from thyroglobulin, and then the condensation reaction is occurring. So nothing much to worry about that. You just write this. This is called the coupling reaction. Coupling. So coupling reaction. COUPLING. On the day of your marriage, you say, nice couple. That is coupling. Wow. People will count relatives. Relatives are what? After a person, you will have only present. But friends will come and say, nice couple. You will very important. You will very nice couple. So from that couple is what? Coupling reaction. This is coupling reaction. MIP either DIP plus DIP or MIP plus DIP or DIP plus MIP. If DIP condenses into MIP, it is reverse T3. If MIP condenses into DIP, it is T3. And if two DIPs, then T4. This is occurring with the help of the enzyme. Write the name of the enzyme. What you are writing? Because a company offers even thyroid peroxidase. In some cases, thyroid peroxidase is also has a role in iodine incorporation also, but at least it has a major role in this complication. Thyroid peroxidase. Okay, this is the name of the enzyme. Right? Now, what is the fate of the iodine? This is required for this thyroid hormone synthesis. So, T4, whatever T4 is secreted into the blood, okay? Some amount of T3 is also secreted, most of it is T4. What is the circulating level of T4 and T3? Before fate of iodine? Then yes, it is invented in 40 times, 40-50 times. And it is a microgram, not gram or milligram. What is the level of hemoglobin in blood? 40 to 60 gram per deciliter. So 1 by 1000 of a gram is milligram, and microgram is still 1 by 1000 of a milligram. So very less. Our hormones are not required in abundance. Hormones are liquid in very less amount. So 8 microgram per deciliter is the, and more than 99% of it is protein bound. Only more than 90, less than 1% is even less than 0.5% is free. But it is the level of the free hormones which are physical. Free hormones are physiologically active, but most of it is protein bound. Why? You can ask for a free hormone, the work will be done by the free hormone, but actually it is protein bound. Why? Why is like this? Because it serves as a food. Free hormone is basically free. Feedback का क्या है? You have learned about negative feedback. Whenever the level of a particular hormone increases, it will send the feedback to the pituitary, and pituitary will send the feedback to the hypothalamus. So T3, T4 has increased. Mainly, this feedback depends on the, in case of thyroid hormones, it depends on the free levels of T3 in the plasma. So 0.2 99% is protein bound. Less than 1% of 0.2. If that increases, then it will send negative, that is negative feedback to the pituitary. That will cause the pituitary to secrete less TSH, pituitary sends feedback, less CRH from hypothalamus. This is simple. Thyroid releasing hormone less from hypothalamus, TSH less from pituitary, and then T3 levels will be brought back to normal. It is the which is more biologically active, which is causing the physiological action, free levels of T3 and free hormone. So, when you learn medicine, you will learn it is the free hormone, free T3, T4 level. Free T3, free T4, and so most of it is bound T3, bound to proteins, bound T3, bound to proteins, but less than 1% at the level of T3 dictates this negative feedback, positive feedback, not positive feedback, negative feedback. Feedback to pituitary and hypothalamus for bringing it back. If T3 is very less, then that feedback will go TSH, CRH, TSH will increase. This is regulation. But regulation coming to go on T4, that will be the next class. I don't know, take 2 classes, physiological actions Regulation, physiological action, and effects of hypothermia next class. Class is not over. Class is not over. Just so T4 is these are the levels. So see, most of it is T4, and out of this 8 and 0.2, more than 99% is protein bound. Now, what are the proteins? So, what is the level of state of iodine? So, most of the iodine particles it will be desaturated. So, the MIT and DIT will attach, but it will remain in the colloid. Some of the iodine will be excreted. Even some of the hormones will also be excreted, but most of the iodine will be desaturated. So, that is the reason why even if iodine deficient diet for 3 months, then also level of thyroid hormones in plasma does not decrease, physiological actions are well maintained up to 3 months. After that, it will start to show signs of deficiency, that is hypothyroidism. With signs of deficiency, hypothyroidism and mainly the physiological actions will come into the next class. And what are the proteins to which this protein binding? What are the proteins? Write it as PBD, thyroid binding protein, PBD. Simply write it as PBD. So, thyroid binding protein, albumin, transthyretin. Transthyretin was earlier called thyroid binding pre-albumin. So, if you don't remember that, that's known transthyretin and PBD. So, highest affinity means which is the affinity basic. Affinity is attraction to T4. Most of the thyroid hormone is T4. The blood T4 will be bound to EBG. But which is more saturated? There is a difference. More affinity for T4. Maybe in protein binding, most of the hormone is T4. More affinity for this T4 is by EBG. EBG has more affinity more than the other two. But which of these is more saturated by T4? That is albumin. Most of the albumin is occupied by 98% of albumin is occupied by T4. But more affinity is towards EBG. Just know this. These are the three proteins to which thyroid hormone will be attached. That is protein bound. That is bind. But the free form will dictate the physiological action as well as the feedback. So basic structure, synthesis, secretion and regulation. Regulation is one of the more things of more regulation. So that is today's class. Next class will be regulation and physiological action. Very important. Another straightforward question. Actions of hormone. Physiological action of the thyroid hormone. Effects of thyroid hormone on this system, on growth, cardiovascular system, metabolism, what metabolism, on fat metabolism, like this. Effect of thyroid hormones, and then effect of deficiency of thyroid hormone or excess of thyroid hormone in the body. So, 2 classes, another class will be required on this topic. Synthesis starting from the book, any book which you are using, and make a note that this is a straightforward short question for not for 15 months I think, but it will be one part of the 15 months. Okay, maybe for 10 months or 8 months. And physiological actions is the next another straightforward question which we will be discussing in the next class.
Your theory topic which is already complete in your theory classes, that is lipid metabolism. Lipid metabolism. As you already know that lipid molecule is basically a complex molecule which are insoluble in water and insoluble in water solvent. Okay? And it is a secondary source of energy. Why it is a secondary source of energy? Because when the body takes the energy from the primary source, carbohydrate. Then in different condition, different pathological conditions, the body takes energy from fat. Okay, that's why it is called reserve source of energy. So I think you already know the different, if you know the classification of the lipid molecule, that it is classified as simple lipids, compound lipids or conjugated lipids, and dried lipids, and miscellaneous lipids. Okay? These are the classifications which are mainly classified on the basis of their structure. We started this metabolism with different molecules metabolism, like triglyceride synthesis, okay, TG synthesis, fatty acid with beta oxidation of fatty acid, omega oxidation of fatty acid, on the basis of number of carbon molecules which is present in this fatty acid chain, okay. So all these are the metabolism. And lastly, lab protein metabolism, conjugated lipid molecules. Okay. So now today we discuss about the beta oxidation of fatty acid. Beta oxidation of fatty acids. Now you will tell, because this is a discussion topic, you will tell something about the beta oxidation. Tell me one by one. Tell me, what is the site of beta oxidation of fatty acid? No, I am not asking to all of you. This is just a discussion topic. Yes, okay. What is the site of beta oxidation of fatty acid? Mitochondrial matrix. Tell me clearly, is at the site of this metabolic pathway is mitochondrial matrix, beta oxidation of fatty acid. But where is alpha oxidation of fatty acid occur? Huh? Peroxisome? Very good. It is in microsomes or endoplasmic reticulum. There is omega oxidation. It is in that side. Some portion in the endoplasmic reticulum and some in mitochondria. Okay, these both are. Now, in this metabolic pathway, we started with the first step. We start the metabolism of even fatty acid chain carbon molecule, that is palmitic acid. Okay? Digestion and absorption you already completed. I am not revising all this topic. Be concerned with the small group discussion, only the main topic. What is the meaning of M? MEC to a MEC? Huh? Monoacyl glycerol. Only 3 students, 4 students can study this topic. Mobilization of fatty acid from triglyceride. Students, the meaning of this, what is the meaning of this? Means lipolysis means breakdown of lipid molecules. Okay, as I told you many times that triglyceride is what? It is a 3 molecules of glyceride molecules, glycerol. Okay, and when it combined with the fatty acid chain, okay, when it combined with the fatty acid chain, they can be stored in the form of triacylglycerol. But when the breakdown of this triacylglycerol occurs, they go in further process of production of free fatty acids, and these free fatty acids used as a source of energy. Okay. Now you will see that adipose tissue is generally a storage form of energy, storage form of fatty acid, which is go by hormones and stuff like this. We discussed this before. How many students agree that we discussed in before? Raise your hands. Raise your hands with confidence. Are you in the third class of lab protein metabolism? You are present? No. No. How many students attending the lipoprotein metabolism class?
So one class.
You were substitute. Only one student. Student, don't treat like a burden to me. I am not here to push you to the next class. If you are not interested to the subject, you are not interested to the topic, why he push you? Blood capillaries. Okay, read the Harper for this for more clarification of this concept. Okay, when this is contact with the triacylglycerol, it converted triacylglycerol into triacylglycerol DHA molecule and monoacylglycerol lastly converted into glycerol plus free fatty acid. Okay, so there is breakdown of this lipid molecule. So it forms glycerol and fatty acid. These glycerol utilized again in the glycolysis process for the production of pyruvate. Gluconeogenesis, you already know what the meaning of gluconeogenesis?
Yes.
What is the meaning of that? Formation of a new molecule from non-carbohydrate moiety. Non-carbohydrate moiety. Substrates are, which one example? Lactate, lactate, gluconeogenic amino acids. Okay, so all these are the substrate of gluconeogenesis. And these fatty acids going for fatty acid oxidation for production of ADP. For production of ADP. Okay. So in this fatty acid oxidation, there is beta oxidation of fatty acid. Okay. Now you see glycerol, glycerolate, dihydroxyestone phosphate. These are the metabolites of glycerol. Now first one is it is a site for the oxidation of fatty acid, beta oxidation of fatty acid, which is occur in the mitochondrial matrix. But before the molecule enter in the mitochondrial matrix, there is a one part is activation. That means it can modulate these molecules for further metabolic process. Okay? So here fatty acid with the help of acyl co-synthase, it will convert it into acyl CoA. That is active fatty acid molecule. Now these fatty acid molecule going to the mitochondrial matrix, going for further production of ADP. Now this is the step, activation of fatty acid to acyl CoA. First step of beta oxidation of fatty acid. Beta oxidation of saturated carbon fatty acid molecules. We can convert it this reaction of sequence oxidation of aridity, hydration oxidation of aridity and cleavage. Such reactions are occur. But now we see the main thing, palmitic acid. Palmitic acid is what? How many carbon molecules? Fatty acids? 16 carbon atom. 17 carbon atom molecule is called steric acid. 20 carbon molecules arachidonic acid. Arachidonic acid. 18 carbon atom molecules. Which one is linolenic? Linolenic, what is the difference between linolenic and linolenic? Huh? So this is the step in which 16 carbon molecules by the activity of acyl CoA is converted into fatty acyl CoA. It is first step of fatty acid molecule, that is activation of fatty acid. Here these molecules become active by the addition of acyl CoA. Okay? Then it is entered in the mitochondrial matrix with the help of carnitine transporter molecules. Their receptor which is present. Okay. So in the next step, there is fatty acyl CoA. It converted into alpha beta unsaturated fatty acyl CoA by the activity of enzyme acyl CoA dehydrogenase. Acyl CoA dehydrogenase. And these dehydrogenase molecules depend on FAD and FADH2. Okay? Where is the FAD can proceed other metabolic pathways? Krebs cycle. Respiratory chain metabolism में जाता है. Respiratory chain metabolism means what? Electron transport chain. Electron transport chain. You will think that all metabolic pathways are relatively attached with each other. This is called integration of metabolic pathway. The term we use, integration of metabolic pathway. So now this alpha beta unsaturated fatty acid acyl CoA is converted into L beta hydroxy fatty acid acyl CoA by the activity of enoyl CoA hydrate. Basically, students, this is the metabolic pathway and they are having separate stepwise process. So, what is the method to learn this metabolic pathways? How will you learn all these metabolic pathways? You will tell? Flow chart what? You learn the flow chart. Actually, no, clinical importance is the other thing. But my question is from your exam point of view. If you are not knowing the basic thing of the topic, how do you write in your copy? My question is that. My question directly to you, because in the exam there is no such time to elaborate the question in detail. If somebody is asking, write about beta oxidation of fatty acid with the regulation and all the clinical interpretation with that. So there is no too much time to elaborate the questions. So what are the important things in that time? You have to write the sequence of all this metabolic pathway.
Definition, site, proper pathway.
Definition, site is okay. You will get this. But important is what? Important is your metabolic pathway. Because as an examiner, if I will check your copy, what I will see you? I will see this metabolic pathway with enzymes. The enzymes is correct, your metabolic step is correct, then we will give you the answer. So for learning this purpose, you have to learn all these things. You make the practice in your copy. इस मेटाबॉलिक पाथवे को 10 बार लिखिए, ठीक है. जब इसका अच्छा प्रैक्टिस करेंगे ना, तब आपको क्लियर हो पाएगा ये मेटाबॉलिक पाथवे. और देयर इज नथिंग टू अंडरस्टैंड. सीधा मेटाबॉलिक पाथवे हाइड्रेटेज है, H2 मॉलिक्यूल एडिशन हो रहा है, ठीक है. आप अगर एंजाइम्स अच्छी तरह पढ़े हैं तो आपको समझ में आएगा कौन सा एंजाइम्स कौन सा फंक्शन कर रहा है. अंडरस्टैंड? इफ यू रीड द एंजाइम्स क्लासिफिकेशन वेरी वेल, you easily understand what this enzyme doing in this step. Okay, so there is L beta hydroxy fatty acyl CoA, means there is the attachment of water molecule by the enzyme of enoyl CoA hydrate. Now beta hydroxy acyl CoA dehydrogenase enzyme activity again with NAD and NADPH activity, it forms beta keto fatty acyl CoA. Beta keto fatty acyl CoA. Now, in the next step, with thiolase, beta keto fatty acyl CoA gang, with thiolase activity, there is the formation of fatty acid acyl CoA and beta fatty acid acyl CoA plus acyl CoA plus these acyl CoA going to the next step of ATP cycle, and there is the final formation of palmitoyl CoA into 8 acyl CoA. 8 acyl CoA. How much molecule are formed? 8 acyl CoA. 8 acetyl CoA. How much molecules are formed from palmitic acid?
8 numbers of
Yes. Now this is important because question is asking metabolic pathway. All of you write the metabolic pathway very easily because you learn this. Because this is the important question. You read all this metabolic pathway by step, but regulation is important. Okay. So complete beta oxidation of palmitoyl CoA occurs through 7 cycle of beta oxidation. How much it yield? It yield 8 acetyl CoA, 7 FADH2 and 7 NADH2. So how much ATP is produced? Calculate it. बताओ कितना आएगा ATP? 1 molecule acetyl CoA produce how much ATP? Total 108 ATPs are produced. 108 ATPs are produced. So all of you write this. All of you write this to learn this very importantly. That complete beta oxidation of palmitoyl CoA, that is 16 carbon atom molecules, it's going to the 7 oxidation cycle. It produces 8 acetyl CoA, 7 FADH2 and 7 NADH, and ultimately produces 108 ATP. How? You make your own calculation. This is a calculation. 1.5 ATP from FADH2, 2.5 from NADH, and 80 ATP from 8 molecule of acetyl CoA. So it means 1 acetyl CoA produces how much ATP? 10. So overall is 108 ATPs are produced. So its ATPs are produced by beta oxidation of fatty acid from the mitochondria. But during the activation, there is utilization of 2 ATP. So when we talk about the net productions of the ATP, then we minus these 2 ATP and it is finally produces 106 ATP. So when we talk about net production of ATP from the beta oxidation, from activation of the molecules also, so there is 106 ATP. How much ATPs are produced? 106. Now the regulation. So carnitine lymphatic this is CAT1. Carnitine lymphatic is a rate limiting step of beta oxidation pathway for the formation of acyl carnitine, which is catalyzed by carnitine lymphatic CAT1. This is CAT1 is basically where it is present in the first step during the activation of molecules. Okay. If this enzyme activity, why it is called rate limiting step? What is the meaning of rate limiting step? जिससे पूछूंगा वो आंसर देगा फ्रॉम द लास्ट बेंच. What is the meaning of rate limiting step?
So the step at which the rate of the whole reaction is decided.
And
Step at which the rate of the whole reaction is decided.
Is? Forward or no? Next, you tell.
जिस स्टेज में और रेट डिटरमिन मतलब मिडिल
वो तो वर्ड ही कह रहा है उसका रेट लिमिटिंग स्टेप है. Means here we talk about the regulation, that is the regulation of heat oxidation. So in this step, these metabolic pathway being regulated, either it produces it concerned in a high energy, high production of ATP, low production of ATP. It is mainly regulated by some of the key factor, that is enzymes. Okay. So carnitine transferase is what? It is the enzyme which is present in the activation of these fatty acyl molecules. Okay. So if this enzyme activity is low, there is low activation of palmitoyl-CoA. If it is high, is rate limiting. This enzyme activity is high. So what happens? There is more activation of fatty acid acyl-CoA. Palmitoyl-CoA. Cat1 is an allosteric enzyme. What is the meaning of allosteric enzyme? जैसे पूछूंगा वही आंसर देगा because it is discussion. This is not a class. Yes, you tell madam. What is the meaning of allosteric enzyme? You tell. Stand up. You are reading enzyme? हाँ? बायोकेमिस्ट्री पढ़ी कि नहीं पढ़ी? क्या पढ़ा? Silent please. Yes. क्या पढ़ा? कौन सा टॉपिक पढ़ा? Allosteric means other than activation site of the enzyme. Because if you see the structure of enzyme, there is two sides, activation site and inhibition. Okay. So there is other than activation site. So it is called allosteric enzyme. And malonyl is the inhibitor of CAT. Means both the enzymes structurally are same. If you read the competitive inhibition, then this is an example of competitive. There is a competition for the binding of attachment of this sites because it is structurally analog with each other. Students, if you want to gain the number in your marking, use a proper language. Structurally analog is structurally similar with each other. That's why there is a competition for the attachment of active site. If this malonyl is attached at the active site, the metabolic pathway become reduced. Okay, it is regulated, inhibited. In well-fed state, due to increased level of insulin, concentration of malonyl increases, which inhibit CAT1 and lead to decrease in fatty acid oxidation. Can anyone clarify this point? कौन क्लैरिफाई करेगा? आप करने की कोशिश करो. हाँ, यस. आराम से बताने की कोशिश करो क्या कहना चाह रहा है इसमें. Don't think I am interrogate you. I am just discuss this topic with you because this topic is already completed.
Sir, fatty acid ultimately acetyl CoA बनाएगा. acetyl CoA वो glycolysis में चला जाएगा, TCA साइकिल में चला जाएगा. तो अगर मैंने ऑलरेडी वेल फेड स्टेट है तो TCA साइकिल ऑलरेडी ठीक ठाक काम कर रहा है क्योंकि वो ग्लूकोज से ऑलरेडी एसिटाइल CoA मिल रहा है उसको. तो उसको ये फैटी एसिड का ऑक्सीडेशन नहीं करना पड़ेगा क्योंकि ग्लूकोज.
This is not the things. Anybody from you? Anybody? This is hormonal regulation of heat oxidation. It is not feedback. It is hormonal regulation of beta oxidation of fatty acid? Because, sit down, because insulin, what the insulin do? They do two processes, dephosphorylation and dephosphorylation. And some of the enzymes can favor dephosphorylation, some of the enzymes can favor dephosphorylation. So in a well-fed state, well-fed state means in the post-prandial condition. After the eating of the meal, you are in well-fed state, there is a production of insulin, and if the production of insulin occur by the, where it is produced? From the beta cells of pancreas. Okay. So if the insulin is produced in a proper amount, they can make the concentration of malonyl-CoA increase. If the malonyl-CoA increase, they can inhibit the fatty acid oxidation by reducing the activity of CAT1.
So melatonin को एक कैसे बढ़ता है इंसुलिन के बढ़ने से?
इंसुलिन के बढ़ने से malonyl-CoA का concentration जो है ना affected करता है. मतलब कि enzymes are present in a pro-enzyme form. It is activated in the presence of insulin. Okay. So, are you understand this point? All of you? The insulin make the two state, dephosphorylation and dephosphorylation. And these enzymes can, some enzymes can favor dephosphorylation, some enzymes can favor dephosphorylation. Okay. In starvation, due to increased level of glucagon, concentration of malonyl-CoA increases and it stimulates the fatty acid oxidation. Just support is where glucagon is present in this metabolic pathway. बताओ ग्लूकागॉन कौन से मेटाबॉलिक पाथवे में होता है? It is the antagonist of insulin and it is present in gluconeogenesis. In which metabolic pathway? Gluconeogenesis. Okay. So what the glucagon do? Glucagon can do formation of the glucose from non-carbohydrate body. So it can promote the production of the glucose from fatty acid. So ultimately this malonyl-CoA, if the malonyl-CoA concentration is decreases, it can increase the utilization of fatty acid. Understand? Listen, in the starvation condition, right? What I talk about? You listen here, what I tell you. In the starvation condition means what? In the empty stomach, you are not taking any meal. There is the utilization of fatty acid in the utilization of fatty acid for the normal functioning of the body. Why it is utilized? Tell me. Tell me. So what happened? Not think like that. There is no glucose, no ये, no glucose नहीं है तो क्या हो गया? Very good. They can correct it. There is no production of the insulin. No insulin. Insulin is produced, but it's not in appropriate amount. Okay. But after the post-prandial timing, after the 14 hour and 16 hour, there is production of glucagon. What the glucagon can do? Utilization of fatty acid for the production of glucose. Understand? They can maintain a regulation of homeostasis process. This is called homeostasis process. Understand? If there is glucose is not present, there is well-fed state of carbohydrate that is not present, there is no net production of the insulin occur. If insulin is not present, up to 12 to 14 hours, there is production of glucagon, which ultimately strike the fatty acid molecules to provide the energy for the body. तो कहती है भैया बॉडी में एनर्जी प्रोवाइड कराओ, तो वहाँ पे क्या होगा? क्या होगा? These fatty acid molecules can utilize to formation of glucose or then further production of energy. Now you see that well-fed states means in post-prandial conditions, maximum glucose level and there is maximum production of acetyl-CoA by which metabolic pathway? You tell which metabolic pathway? Glucose to formation of acetyl-CoA by which metabolic pathway? Which metabolic pathway? Glycolysis. You are not telling the right answer. Glycolysis. Okay. So in the well-fed state, there is insulin production is occur. Due to the insulin, there is acetyl-CoA carboxylase enzyme activation, and these activation can occur malonyl-CoA concentration, and these metabolic pathway can regulate it from this condition. You understand all these things? What I tell you, what I directly tell you, that insulin can increase the concentration of malonyl-CoA. If this malonyl-CoA increases, they can suppress the activity of carnal lysan transferase enzymes, CAT first enzyme activity. If the activity of CAT first enzyme activity is suppressed, so there no entry, no these fatty acids are not entered in the mitochondrial matrix, and there is no further beta oxidation process occur. Understand? Same as in the condition of starvation. Starvation condition, production of glucagon, and these can activate the malonyl-CoA, and these malonyl-CoA can bind up with the carnitine transferase, and they can reduce the activity of increase the activity of carnitine transferase, and due to this there is beta oxidation of fatty acid process fast. Means this metabolic pathway can occur fastly in the starvation condition. स्टार्वेशन कंडीशन, ठीक है. भूख हड़ताल में जब कोई भूख हड़ताल में बैठता है ना, तो कैसे भूख हड़ताल में कोई भी पर्सन ऐसे 15-20 मिनट तक भूखा रह जाता है, बताओ. Why some people are to be in starvation condition? They can live up to 10 to 12 days or 15 days, 21 days. How? By this process. Firstly, body needs energy. They can utilize the carbohydrate molecules. After then, it can utilize the fat and then go for protein. Okay. And how this protein utilizes? When the proteins are break down into amino acids, these some amino acids are gluconeogenic amino acids. These gluconeogenic amino acids going directly to the which metabolic pathway? Gluconeogenesis. First thing. Secondly, fatty acids. So body can regulate it. Body can regulate all this by different metabolic pathways. Now this is important. This is important only beta oxidation of fatty acid. But sometimes the question will be asked like oxidation of fatty acid, odd number of carbon atoms. You all of you read from this book. Okay, there is nothing to understand, but you understand only this. Why it is important? What is the significance of beta oxidation of fatty acid? What is the significance of beta oxidation of fatty acid? Now you can relate this with a clinical condition. In the case of diabetes mellitus, there is no production of insulin. Okay, so body takes fatty acid as a source of energy. If the body takes high amount of fatty acid, what happens? There is more production of ketone bodies. But there is a process called diabetic ketoacidosis occur. Diabetic ketoacidosis occur. So students, this is the one topic of discussion. You can read this topic in your whenever you time. Next time I have questions, you will ask to me any of the questions. You will read this topic. Oxidation, hydration, oxidation by energy, cleavage, all this process you need. That is 16 molecules produce 8 molecules of acetyl-CoA. Okay. Net production of ATP is 106. Overall production of ATP is 108. There is first step is called activation of acetyl-CoA is important because it is a rate limiting step. rate limiting step. All of you read this. This topic I will come within 5 minutes. Then I will take your attendance. So this is the structure of all the ketone bodies: acetoacetate, beta hydroxybutyrate, and acetone, which is volatile in nature. Okay. So, in case of diabetes ketoacidosis patient, there is a word osmol breathing. Osmol breathing. What is the meaning of osmol breathing? During diabetes mellitus condition, there is a high production of ketone bodies occur. Okay. So there is only ketoacidosis occur, and there is more ketone bodies are occur. Acetone are occur. Okay. So during when there is any kind of acidosis, you already completed acid and biliary topic. Okay. When any kind of acidosis occur, there is a compensatory mechanism activated. Compensatory mechanism activated means buffer actions is activated. Okay. So respiration through the lungs, it can maintain this buffering action by the taking of CO2 and carbon. So when the patient come, diabetic ketoacidosis patients are come in the emergency ward, there is a fruity smells occur. Some fruity smells occur from this respiration. So that type of respiration called osmol breathing. Understand? That type of respiration is called osmol breathing. Acetone, beta hydroxybutyrate are interconverted by the mitochondrial enzyme beta hydroxybutyrate dehydrogenase. Acetoacetate continues to undergo spontaneous non-enzymatic decarboxylation to read acetone. The concentration, it is 2 millimole per liter. Okay. So if the concentration is more, what happens? There is ketonemia. Okay. When the concentration of the ketone bodies are high in the blood, it is called ketonemia. When this occurs in the urine, it is called ketonuria. When both the clinical condition occur in the same patient, it is called ketosis. Understand? Now this is the interconversion process that acetoacetate is converted into acetone and is converted into beta hydroxybutyrate. So during Uthra's test, there are 2 ketone bodies give the positive test. Which one? Acetone. Why beta hydroxybutyrate does not give positive test? Hey, I am not asking to all of you. तो भेड़ चाल मत किया करो. Yes. Ketonic structure is not there. Okay. ये दिया हुआ है एक्सक्रीट थ्रू द लंग्स. Ketone bodies are water soluble energy yielding substances. Acetone is an exception since it cannot be metabolized and it is readily excreted through the lungs. So during diabetic acidosis condition, it is excreted through the lungs. So there is smelling of fruit smell and acetonic smells. So this is called osmol breathing. One of the symptoms of diabetic ketoacidosis is subject. Formation of ketone bodies, it is in the liver. Ketone bodies are synthesized and transferred to other organ as a fuel. Which organ can take as a source of energy? Brain. Very good. Brain. The synthetic ketone mitochondria of hepatic cells. So this is the first step of condensation reactions in the ketone bodies. Metabolism. Acetyl-CoA, 2-acetyl-CoA forming molecule, acetoacetyl-CoA by the activity of amylase. Okay. And in the next step, there is HMG-CoA synthetase, formation of beta hydroxy beta methyl butyrate-CoA, HMG-CoA. Okay. Again, this is the rate limiting step of this metabolic pathway, HMG-CoA synthetase. It is a rate limiting step, very important. And lastly, by HMG-CoA lyase, it forms acetoacetate. It forms acetoacetate. And after this non-enzymatic decarbonization process, the other types of ketone bodies are also formed. It is called acetone. Second one is beta hydroxy butyrate. Understand? So it is utilized. Site of the ketone bodies production is liver, mitochondria of the liver, and second one is ketone bodies cannot utilize. These questions asked in your generally the examiner asked why these ketone bodies are not utilized. The next class में करेंगे. In the next class we discuss in detail all this.
Okay, so appendix, you know, it is a last part of the large intestine or first part of large intestine. What you want to say? It is the first part, but where does it arise? কোন জায়গা থেকে আসে? So it is it coming always from cecum? So it is not right. Okay, developmentally it will at first it will arise from cecum. Afterwards, where it will go to the posteromedial wall of the abdomen. Okay, পিছনের দিকে চলে যায়. So that you know. Please write it down. Please don't take the snapshot. Take the note. It is also known as vermiform appendix. So why it is called as vermiform? Because it's looking like a worm. Okay, and you know it is a vestigial organ. Okay, and what would be the definition? Last page. So it is a blind-ended tube. Okay, remember it is a blind-ended tube. It arises from the posteromedial wall of the abdomen, and there are two valves present in the large intestine. Who will say? What are the two valves present in the cecum? একটা হচ্ছে ileocecal valve and another is known as appendicular valve. Okay, in between means there is two opening. Okay, one is ileocecal opening, another one is appendicular opening, and appendicular opening is about 1 centimeter below than the ileocecal valve. Write this down. Okay, it is about 1 centimeter below the ileocecal valve. Okay, and what would be the length? Length new question asks. Okay, it may vary person to person, it may vary, but what is the approximate length? It is about 9 centimeter. Okay, but it may vary 2 centimeter to 20 centimeter. Okay, so that is the length of the appendix. Appendix is a very nice subject. Okay, for in case of anatomy as well as surgery. Okay, because numerous cases. Okay, how you know one patient having appendicitis? Have you seen any patient or any relative or anybody who has this appendicitis? কি হয় appendicitis এ কি হয়? There will be extremely pain. Okay, pain where you know the location of appendix, right iliac fossa, যেখানে আরেকটা কি বলে ম্যাকবার্নিস পয়েন্ট. ওকে, আর কি থাকবে? there will be raised temperature, fever হবে, আর কি হবে? vomiting হবে. So these three are the criteria of appendicitis. Okay, pain in the right iliac fossa. Okay, then there will be fever and vomiting. So these three are the feature of the appendicitis. Okay, so what are the parts? Next question is what are the parts of the appendix? So appendix has got जहाँ से वो stem arise करता है, that is the base. Okay, then next one is the body of the appendix, so that may be 9 centimeter, and then there is a tip of appendix, the pointed end. So now the question already I told, where does the base arises? Base টা stem টা কোথা থেকে arise করে? It's very important. Suppose you are doing a appendectomy, you have to know where is the place of the appendix. Okay, so doing the surgery you have to know what is the correct position of appendix. প্রথমে আমরা কি দেখব? large intestine press করে আমরা cecumটাকে press করব. Okay, and from where the appendix will arise? From the posteromedial part of the abdomen. Okay, So these are the three parts: base, body, and the tail. Okay. So now, why it is called? These are all questions. Okay. These are all explanatory note. Also, you could take that why appendix is known as abdominal tonsil. I discussed so many times why it is called abdominal tonsil. Tonsil kage bole? How many times I will say you? Who will say? Aggregation of lymphoid follicles. So সেরকম aggregation of lymphoid follicle কোথায় থাকে? Appendix. Okay. So this is the submucosa. কোন লেয়ারে থাকে? Submucosaয় থাকে. Okay. So the submucosa contain many lock this one. Okay, the submucosa contain many lymphoid follicles or aggregation of lymphoid follicles. So it is the one MCQ. Okay, where you will get the lymphoid follicles in the submucosa. Okay, so what are the layer? What are the four layer of GI tract? Who will say me? What are the four layer of GI tract from inside to outside? প্রথমে সাবমিউকোসা থাকবে মিউকোসা, মিউকোসা, সাবমিউকোসা, then muscularis externa, serosa. Okay, so where you will get these lymphoid follicles? In the submucosa. Okay, so even arterioles and vein also at the submucosa. Okay. Okay, so see here, this is the appendix, right? So here is one important thing that is known as tinea coli. So tell me which one is the tinea coli? Konta tinea coli? You see, this is the base of the appendix. Okay, so from where this base of the appendix going throughout the intestine, this longitudinal band you could see, this is known as tinea coli. Okay, so how to trace the appendix? You have to trace this longitudinal band. Okay, so you could trace downwards where you will get the appendix. Okay, surgeon also used to do this thing. They will trace the tinea coli. Colon is very easily identified, so they just trace the tinea coli. Where it finish, at that moment you will get the appendix. Okay, so where it found? At the stem. And what is this? See this yellowish color? This is what? This is the ileum, right? This is the cecum. So valve is, one opening is ileocecal valve, another one is appendicular opening. Okay, so this is about 1 centimeter below that. Okay, and what is this yellowish color thing? This is also known as mesoappendix. Ki bole etake? Mesoappendix. So this is the part of mesentery. These are the part of mesentery. আর কোথায় পাবে part of mesentery? Means which are the organ that has got its own mesentery. So the answer একটা হচ্ছে transverse mesocolon. You all know what is transverse mesocolon. Okay, so mesentery present in the transverse colon, and also mesentery present in the appendix is known as mesoappendix. আর কোথায় পাবো? Give me some more example. Do you know? আরেকটা হচ্ছে মেসো ওভারিয়াম। ওভারি যখন ইউটেরাসের সাইডে থাকে সেখানেও কিন্তু পার্ট অফ দ্য মেসেন্ট্রি ইজ এ পার্ট, সো দ্যাট ইজ নোন অ্যাজ মেসো ওভারিয়াম। ওকে, we will come across to the uterus at that time. So see, what about the base? So about the base you have to remember it will be about 2 cm below the ileocecal junction, number 1 point, and second where it is present at the posterior-medial wall, at the posterior-medial wall. So these are the 2 points about the base. So this appendicular opening is guarded by one valve. What is that name? Valve of Jayland. Okay, so this is one MCQ. The appendicular opening is guarded by one valve, that is known as valve of Jayland. Okay, so this is about the base of the appendix. Okay, then how to trace appendix? This thing already I told. You have seen throughout the colon there is tinea coli. Okay, so you have to trace the tinea coli that converges মাসেল কোর। তোরা জানিস মিউকোসাতে কতগুলো মাসেল কোর থাকে? GIT যে মিউকোসা, what are the layer? Mucosa has got 3 layer. From inside কে আছে প্রথমে? Epithelium. প্রথমে থাকবে epithelium. Then next one is lamina propria. Then third layer is muscularis mucosa. Now this muscularis mucosa has got 2 layer, inner circular, outer longitudinal. So these tinea coli will converge where? Outer longitudinal layer. Okay. So these are the surgical dressing of the appendix. Okay. So you could see this is the cecum. What is this? This is the ascending colon. What are these? এটাকে কি বলে? Appendices epiploica. These are our 3 types. তিনটে টাইপের থাকে, ওকে? সেটা এমসিকিউ তে জিজ্ঞেস করে what are the type of appendices epiploica, and you could see this is the ostration. Then which are the tinea? These longitudinal band. Okay, that running through what? কোথায় কোথায় থাকবে না? Except the rectum and anal canal, and you could also see the appendix is devoid of tinea coli. Okay, তাহলে এখানেও কিন্তু একটা এমসিকিউ আসতে পারে যে which are the organ devoid of tinea coli. So next one is McBurney's point. এটা কিন্তু সারফেস অ্যানাটমি তো বারবার জিজ্ঞাসা করে what is McBurney's point. So as you studied the hip bone, you know one thing that is known as anterior superior iliac spine. Okay, so that is the which part? Anterior superior iliac spine the car part, ilium is part. Okay, so one point you have to take from the axis, okay, anterior superior iliac spine and up to the umbilicus. Okay, you have taken drawn one line. Now you will take the medial 2/3 and lateral 1/3. So you will get 1 point. So that point is the maximum point of tenderness. এটা কিন্তু কোনো ন্যাচারাল অ্যানাটমিক্যাল পয়েন্ট না, দিস ইজ আ ফিজিওলজিক্যাল পয়েন্ট। ওকে, যখন ডিজিজ হচ্ছে তখন পেশেন্ট বলবে ওখানে যদি ইউএসজি করা হয় দে উইল গেট দ্য প্রোব টেন্ডারনেস। ঠিক আছে, যেমন ধরো আলসার, কারো যদি আলসার হয় গ্যাস্ট্রিক বা ডুওডিনাল আলসার, হাউ টু ডিটারমাइन? दे विल कीप द यूएसजी प्रोब वहाँ से रखने में बोलेगा कि पेन इज फेल्ड देयर। Okay, so by that way to determine ulcer and appendicitis. You could not see appendix in USG. ঠিক আছে, এমনও হয়েছে অ্যাপেন্ডিক্স বাস্ট হয়েছে, পরবর্তীকালে যখন সিটি স্ক্যান করে দেখা গেছে তখন দেখা গেছে যে তখন অ্যাপেন্ডিক্সের একটা চারপাশে একটা হিমাটোমা পাওয়া গেছে। ওকে, ইউএসজি তে কিন্তু কখনো অ্যাপেন্ডিক্স দেখা যাবে না। Keep this thing in on mind. Okay, if you have to trace, you have to do CT appendix. Okay, CT scan of the appendix. So this is the surface anatomy তে বারবার জিজ্ঞাসা করা হয় what is the point? Medial 2/3, lateral 1. Okay, so see this is the maximum point of tenderness. So that is the McBurney's point. Okay, next one is about the development of appendix. So how does the appendix develops? কি করে ডেভেলপ করে? Are you starting the development or no? So there is a outpouching from the caudal limb of midgut. Just write it down that 3 point. It is from outpouching of caudal limb of midgut. Okay, মানে midgut-এর ওখান থেকে একটা আউটপাউচ শুরু হবে, that would develop 2 things. একটা হচ্ছে cecum আর একটা হচ্ছে appendix. Okay, দুটো জিনিস ডেভেলপ হবে. So that is caudal limb of the midgut. I want all of you to study development of GI tract. Okay, in embryology. Besides study this. Okay. At first, after development, what will happen? The gut will go outside the umbilicus. Okay. Then again, it's come back, and there is rotation of gut. Okay. That you have to know in the embryology. Okay. So this is the development. Okay. So here. How is the change of evolution of both cecum and appendix? What will happen? At first I told you the tip of appendix is present where? The base of appendix is present on the cecum. Okay. So afterwards what will happen? Cecum would be just, there would be unequal growth of the lateral wall of the cecum. Understood? There would be unequal growth of lateral wall of cecum. At that time what will happen? This appendix will go on the posteromedial side. Understood? So just write it down 3 points. At first, developmentally at first, the base of appendix lies at the wall of cecum, at the anterior wall of cecum. Okay, but eventually due to unequal growth of lateral wall of cecum, due to unequal growth of lateral wall of cecum, okay, lateral wall of cecum, the base of appendix originate from posteromedial wall of cecum. ঠিক আছে, তার মানে যদি এটা এক্সপ্লেনেটরি নোট আসে at that time you have to explain, okay, why it shifted. Cecumটা unequal growth হচ্ছে, so that's why appendix is going where, to the posteromedial wall. Okay, so now write it down, what are the different type of position. So why it is important? Because surgeon should know where is the location of appendix. Okay, after opening the anterior abdominal wall, they should know where is the appendix. So how many type are there? At first is retrocecal, very important, retrocecal. Acha, eta that they are saying it is 12 o'clock position, right? So how you will determine the two end of a clock? একটা তো রেট্রোসিকাল, তার মানে হচ্ছে সিকামটা এরকম আছে, তার পিছনের দিকে থাকবে, ওকে, সিকামের পিছনের দিকে থাকবে, তাহলে সেটা 12 o'clock. I am saying that is of one end of the clock. So what about the another one? Means which one is the axis? That's what I am asking. They are taking one clock, so which one is the axis of clock? Write it down. This is nothing but tinea coli. Okay, these are nothing but tinea. You have seen tinea coli is coming. Okay, so that is one limb of a clock, and another is going to the retrocecal, so it is making 12 o'clock. Okay, so retrocecal is maximum, that is about 60 to 70%. Okay, then next one is pelvic position, that is about 20 to 30%. Then next one is promontory. They are saying about the sacral promontory. Okay, sacrum, you have seen the promontory, so that is another promontory. Then next one is the subcecal, preilial, posterior. So how many varieties? 6 varieties. Okay, retrocecal maximum, বাকিটাকে হবে pelvic, and some amount you will also get promontory and subcecal. আর preilial, posterior সেটা very uncommon. So we will see the picture, see here what is happening. So প্রথমে আমরা বললাম retrocecal. So see, this is the one limb. ঠিক আছে, এটা যদি তুই একটা ক্লক ভাবিস, this is one limb. So another one is going here, so it is making 12 o'clock position. Then next one they said that is the pelvic. So this is which o'clock position? কত হচ্ছে দেখে বল কতটা? 6 o'clock. Then next one is this one, 8 o'clock. Okay, then these two, 1 কেন 2 o'clock, 3 o'clock হবে. See this one, this is the axis, tinea coli. This band is tinea coli. Understood? This longitudinal band is tinea coli. তাহলে এটা কি হবে? 2 o'clock, 3 o'clock, 2 position. So you have to take this one. Okay, tinea coli. Okay, then next one is blood supply. But blood supply is very much important for appendix. Why? Because appendicular artery is a branch of iliopolic artery. Write it down, iliopolic artery, which is further a branch of superior mesenteric artery. Which is further a branch of superior mesenteric artery. Okay. And where it originates posterior to the terminal ileum. Originate posterior to the terminal ileum. And most important thing is it is a end artery. এখানে একটা explanatory note আছে why appendicular artery is a end artery. কেন end artery বলা হচ্ছে? Now who will explain me what is end artery? End artery কাকে বলে? এর আগে আমরা পেয়েছি end artery, right? End artery কাকে বলে? হ্যাঁ বল। So there would be no collaterals. ওইটাই last artery. There would be no collateral branch. More specifically, you have to say there would be devoid of precapillary anastomosis. This you have to say. Okay, end artery মানে হচ্ছে devoid of precapillary anastomosis. Devoid of precapillary anastomosis. Okay. And there is no collateral circulation. And there is also no collateral circulation. বোঝা যাচ্ছে? আর কি কি এক্সাম্পল কি হবে? একটা হবে there would be absence of collateral circulation. Okay, and it is devoid of precapillary anastomosis. Precapillary anastomosis. That means that is the last branch. Okay, so what is the other example? Splenic artery. Okay, another example is splenic artery. So these are the two end artery. Aro end artery পাবো. Okay, gradually we will come across. So now end artery তে কি সমস্যা? End artery হলে যদি ধর anyhow blood supply is diminished. Okay, or there is ischemia. What will happen? There will be necrosis. ঠিক আছে, সেই জন্য কিন্তু অ্যাপেন্ডিসাইটিস হলে উই অলওয়েজ সি অ্যাকিউট অ্যাপেন্ডিসাইটিস যে হলেই সার্জনরা অপারেট করে, রেখে দেয় না। Why? Because that may go to the necrosis. ঠিক আছে, blood supply required by necrosis. You see, this is the artery. So you could see what is this? This is the iliopolic artery. Okay, from that which artery is coming? That is the appendicular artery, main branch. Okay, and what is this? This is the mesoappendix. যার মাঝখানে কি আছে? mesentery. And see from where it arises? The back of the posterior to the terminal ileum. Okay. So now the nerve supply of appendix কি কি? T9 to T10. Okay, এখানে একটা কোশ্চেন আছে যে কেন আম্বেলিকাসে ম্যাকবার্নিস পয়েন্ট আমরা বলছি। ঠিক আছে, the patient having appendicitis also felt pain on the umbilicus. কেন? Because same segmental nerve supply. Umbilicus কেও করবে T10, appendix কেও করবে T10. Okay, you could also write down the nerve supply of umbilicus is T10. Okay, nerve supply for the umbilicus is T10. And parasympathetic supply is what? Vagus. Okay. So whole GIT parasympathetic supply is by vagus. So this is the longest cranial nerve. So which nerve having longest intracranial course? Longest intracranial course. কতগুলো cranial nerve আছে বল? 12 nerve. এবার আমি বলেছি which has the longest intracranial, মানে ব্রেনের মধ্যে উইদিন দ্য স্কাল তার মধ্যে কোনটা বেশি কোর্স আছে, কোন নার্ভ? কে বললো একটা বল? তুই বললি? ট্রাইজেমিনাল বললি না, ট্রাইজেমিনাল হচ্ছে থিকেস্ট নার্ভ. This may comes as MCQ. Okay, most thickest nerve is the trigeminal, but answer would be trochlear nerve. ঠিক আছে, you will get repeated time of MCQ this one, longest intracranial course কে trochlear nerve. Why? কারণ এই নার্ভটাই পিছন দিক থেকে বের হয়, মানে posterolateral aspect থেকে বেরিয়ে সামনে আসে. Okay, so it has the longest intracranial course. Okay, so next one is lymphatic drainage. So it passes through the cecum, and iliopolic artery. Okay, lymph nodes will be going over there. Now what is mesoappendix? Mesoappendix means this is the mesentery. Okay, these are the lining mesentery that covers the appendix. এরকম কোথায় পাবো আমি অলরেডি ডিসকাস করেছি, একটা হচ্ছে ট্রান্সভার্স মেসোকোলন আর হচ্ছে ওভার meso ovarium. Okay, these are the mesentery. So you have already seen it is a triangular fold of mesentery. Now these are the sign. Okay, so I told you this thing, what is Murphy's triad. Last page, get up. You get up. Yeah, you get up. I told you Murphy's sign, right? What are the three triad you will get in patient of appendicitis? I told in before. At the beginning of class, I told you there are three things. Bol ki hoy? Symptom ki একটা appendicitis এর patient এসে how you will determine? Umbilicus is very good. আর কি হবে বল? মানে pain in the right iliac fossa. Okay? হ্যাঁ ওটা তো একটা হয়ে গেল। আর ওটা তো অলমোস্ট এক কোর্স পিওর অন্যের সকল already I told in the beginning of class बोलो 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 और क्या होगा appendicitis में fever হবে আর একটা কি হবে vomiting. So these three are the Murphy's triad. Okay, so I did because you will remember throughout your life. Okay, so these are the three triad. One is pain on the right iliac fossa, then there will be fever, then say third point would be there will be vomiting. Okay, so these are the Murphy's triad. Okay, then write it down another one. What is Seren's triangle? Seren's triangle, it is not written over here. S-H-R-E-E-N, S-H-R-E-E-N, Seren's triangle. So see, the next one is Seren's triangle. Write it down. Seren's triangle. Seren's triangle is, so there are 3 points. Okay, one is anterior superior iliac spine. Another one you have getting umbilicus. Now take another point at pubic symphysis. Okay, so just write it down. There are 3 points. Number one is anterior superior iliac spine. Anterior superior iliac spine. Okay, then up to the umbilicus. Okay, then another one is pubic symphysis. Okay, so if you make one triangle, there the patient of appendicitis having maximum pain. Okay, so there is hyperesthesia. Write it down. Hyperesthesia has been failed. Hyperesthesia. Hyperesthesia বলছিস না তুমি hyperesthesia মানে excessive pain. Okay, hyperesthesia over this triangle. Okay, in case of acute appendicitis. Okay, then the next one is see how to elicit the patient having appendicitis. So these are you have to also study in surgery. So first point is Robsing sign. Just write it this sign, Robsing sign. These are also comes in clinical anatomy. Robsing sign. Then next one is Schwartz sign. It is also known as Ilios-Schwartz sign. Okay. Then obturator sign. So these are the 3 signs you will get in the case of appendicitis. Okay. So now we'll elaborate. So see what is happening in the Robsing sign. You will palpate the patient on the left iliac fossa. Okay. So while palpating or while pressing, this bowel loop it will migrate to the right side. ठीक है? So that will elicit pain on this right iliac fossa. Okay. So this is known as Robsing sign. Okay. This is the first sign. Then next one is iliopsoas sign. So iliopsoas se ki korbi? Ask the patient to lie down. Okay, you have to take the right limb. Okay, you will just keep on pressure to flex the knee. Okay, at that time patient will feel pain on the right iliac fossa. This is known as iliopsoas sign. Okay, then what about obturator sign? Obturator internals কোথায় থাকে? কোন কম্পার্টমেন্টের মাসল? It is present on the medial compartment. That means what its function কি হবে? Medial rotation. তাই তো? Medial rotation of the thigh. So you have to flex the leg and you have to do medial rotation of the thigh. Okay, so that means function of the obturator internals. At that time again pain will be felt on the right iliac fossa. Okay, so these are the few signs. By that way you could determine it is the patient having this appendicitis or not. So most common sign কোনটা দেখে? দুটো, একটা হচ্ছে Robson sign and other one is iliopsoas. এই দুটোই maximum দেখা। ঠিক আছে? So this is all about the appendix.